Welcome to the Clinical Excellence Commission. I'm Cliff Hughes and I'm the Chief Executive Officer of the Commission. Today we're going to be talking about open disclosure, particularly high-level open disclosure. By that I mean discussing events that have a severe impact on patients of their families and how to deal with those in the very difficult circumstances that we often find ourselves. Open disclosure is one of the key elements of patient safety and clinical quality, and we're pleased to participate in this education program with you. We really need to start talking about open disclosure from the point of view of the patient. What is it that the patients reasonably expect? Before we do that, I want to take you back to the very early days of my career when we were confronted with a particularly serious event at Royal Prince Alfred Hospital. It was May 1981. I was a young surgeon. We had introduced a technique that enabled us to paralyse the heart so we could do the very fine and complex procedures that are necessary for coronary artery bypass grafts. Two of the surgeons were on leave, so there were two of us left to operate. And over the space of 4 days, we had a series of patients who became sicker and sicker as the week went by. Each of the patients were getting sicker earlier in their post-operative care, and all our tests failed to find out why. Some of the patients were frail, some of the patients had other comorbidities, and some of them were getting sick for no obvious reason. After 4 days, we stopped operating, we reviewed all our programs, we could find no further problems. So we did an extra patient using a slightly different technique and without using this particular solution, which we call cardioplegic solution. The patient was fine, so we continued to operate. On the Monday of the second week, 2 patients were operated upon and both became critically ill while we were still on the heart-lung machine. The 2 surgeons working in adjacent operating rooms both sent samples of the solution across the laboratory to have a gram stain done. The report was phoned through almost immediately. The solutions were teeming with a particularly virulent bacteria. We stopped operating. We immediately embarked on a program of intensive antibiotic therapy for each of the patients. But those patients were to get sicker. Most of them required return to the operating room with infection, with bleeding. They also had lung problems, kidney problems, and 5 of those patients were subsequently to die. It was a terrible time in the life of each of those families and also for all of the staff. One of my senior colleagues who'd come back to help us deal with this issue said we must tell the families what is happening. So we called all of those family groups together, we sat them down in one room, and he and I explained what we knew, which wasn't very much at that time. We knew they had an infection, we knew they were critically ill, we suspected that some may not survive, but we told the patients we would not do any further surgery until all the patients were out of the woods, and we didn't. For 1 month, the whole unit concentrated on saving the lives of these 11 patients. And in half of those patients we were successful. The other half we weren't. We also told the patients we would keep them informed, and if we found out where the infection came from, we would let them know. As it so happens, we were not able to find that out. Subsequent investigations by the hospital as well as our own unit, and indeed by the coroner, failed to find the site of the infection. All the tests in its manufacture in the pharmacy had been completed and were accurate and were free of obvious infection. So somewhere in the process, this solution had been contaminated. A terrible scenario for those patients. But it's interesting to note that none of those families went on to sue the hospital. What was it that enabled us to get through that scenario? Firstly, there was, of course, the teamwork that we had around a very close-knit team, but also the involvement of the families. So why have we embarked on an open disclosure program in New South Wales? You'll be interested to note that this is one of the first jurisdictions to do a mandatory program such as this. Across the country, there are a number of pilot sites that are doing the same work, all based on the standards developed by the Australian Council on Safety and Quality in Healthcare several years ago. But in New South Wales, we've made it mandatory. Why should we do that? Well, the answer, I believe, is simply it is the right thing to do. It is the right thing to do. You see, our patients value good information, and this tells them that we are supporting them in providing quality and safe care, no matter who or where they might find themselves. We need to support open disclosure in all its forms across the state. We need to know as clinicians that we are being supported by the system and by our fellow team members and by the broader bureaucracy. And I can assure you that this program has widespread support. The Department of Health has demonstrated its support by developing a framework, putting a policy in place. As well as that, we've been fortunate in New South Wales that changes to the Tort Law Reform and the Civil Liabilities Act have also made it possible to say sorry without admitting liability in a secure environment. Saying sorry does not commit yourself to a particular course of legal action. In fact, that apology is not allowed to be used in the courts. Open disclosure will not happen unless we exercise strong leadership. It is difficult. It was not easy in 1981 to admit that something that we had introduced in the program in good faith had caused such harm. But we had to do it. Your role is also to support a culture of honesty, responsibility, and open communication and education. You see, our junior colleagues do respond to role models that we exercise in our clinical endeavours. If we are able to apologise even when we handle our staff inappropriately, they will understand that it is okay to say sorry. It is okay to explain what went wrong and to ensure that we're going to make changes. If we are able to do it, then we'll encourage our junior staff to do it, so that when a resident has trouble getting a central line in, or when a nurse omits or is late in giving a medication, they are able to go and say to their patient, look, I'm sorry, I forgot to do this, or I'm having trouble with this procedure, I'm going to get help. You'd be surprised how many times the patients will be the first to reassure the staff. We also need to remember that saying sorry is a critical part of the management of any clinical incident. You will be aware of the framework that New South Wales Health has put around the management of incidents and complaints, for that matter, as well. Saying sorry is the first step. It precedes any other legal action, any other complaint, by weeks, months, and sometimes even years. It is a timely approach to the problem. Well, I guess we really should ask the question, what is open disclosure? The definition is pretty simple. It's a frank discussion with a patient and their support person about a patient-related incident. Open disclosure provides an ethical framework for staff and health services to fulfil our duty of care to patients and their support team. That's all it is. No more complex than that. There are a number of principles, of course, that underscore the way in which open disclosure will work. The first of these is timeliness. We need to say sorry early, as soon as possible after the event. We still may not know why the event occurred, but we can say sorry. Just as if you see somebody fall over in the shopping centre. As you pick them up, you say, sorry, are you okay? We do it at the time. The second principle is that of empathy or compassion. And it's important to recognise that this is not a formality, nor is it patronising. It's understanding or trying to understand how the patient feels, how the family might feel, and to try and recognise the distress that they're going through and work through that with them, just as we would expect if it were our family member. The third principle is that we take the responsibility for the system and for our care of the patient. We are not going to deny that these events took place whilst patients were under our care. That says to the patients, we're on your side, we're part of your team. Of course, we must be honest. We all know the truth will out. But sometimes the truth is hard, and therefore we need to be strong enough to front the truth and to be honest at the time of the event and throughout our dealings with the incident thereafter. The other important thing is that we are transparent. If people can see what we are doing, even if we haven't yet got the final answers, they will understand again that we're on their side. And if we keep our promise to keep them informed, they will be much more encouraged that we are in fact their team. We are in fact their support person. And finally, they do expect that we'll make changes. Patients are distressed when what happens to them happens to somebody else, because it tells them that the system has become apathetic. And for that reason, action is a crucial part of the rollout of open disclosure across the system. Those principles then make it easy for us to understand the key elements of the program. The first thing is, of course, that we acknowledge the incident and its impact on all concerned, not just the family and their support person, but also on the staff as well. We need to be able to explain to our patients what we know. It's important to realise that one of the honest answers is, I don't know yet, but if I do know, I will let you know. We've said time and time again it's important to say sorry and to mean it. We need to also to reassure our patients that we are going to do the best to look after them. In May 1981, we didn't operate on any other patients, and we let our patients know that we were going to concentrate on their needs during that difficult crisis. And we reassured them that we would do all in our power. We should also let our patients know that we're not going to rest on the facts. We're going to investigate everything we can around the incident to find out what really happened. One of the terms that we use, and I'm sure you've heard, is root cause analysis. It's what really went wrong. Not just a guess, but what really happened, so that we can make changes, we can report those changes, and we can improve the system. But all of that is not enough unless we give the feedback to the patient first and their support people. Let them know what we've done and what we are going to do about the issue. But there's another little part about feedback that I think is just as crucial, and that is to let the staff know that we have reviewed this incident and we've uncovered some interesting information which has enabled us to change the system and make sure that the system within that which they work is also a safe and friendly environment. That is a very useful way of handling any incident. Of course we should document it, and we document it so that the facts are known and can be reported to other people in a secure environment, so that other people will learn from the events that we've just gone through. Can I take you back to May 1981? It was a terrible time. One Thursday evening when I'd been called in every night for 7 days, my senior partner said, Cliff, go home, disconnect your phone, take the batteries out of your pager and get a good night's sleep. I'll take all your calls. Friday morning, 7 o'clock, after we'd plugged the phone back in again, it rang. One of the patients was bleeding and needed to go back to the operating room. The registrar informed me that my colleague was already there and they were going back to the operating room, and of course I went back in. That was teamwork. That was action. But you know what? None of those patients took legal action against the hospital or the pharmacy procedures. We went to the coroner's court, as you might imagine. After all had been heard, I had to take the stand. And the coroner asked me very simply 2 questions. What have we done and what were we going to do? What had we done? We'd stopped manufacturing that solution in the hospital pharmacy. We'd found a firm in Melbourne that would manufacture it and supply it commercially. What were we going to do? We had submitted the whole saga to the Journal of Thoracic and Cardiovascular Surgery. In those days, the most widely read cardiac surgical journal in the world. It was accepted, it was published. The coroner's response, thank you, Dr. Hughes, we can ask no more of you, you may go. But even more interesting than that, 10 and 12 years later, when some of those patients required Reoperation, as occasionally occurs with coronary artery bypass surgery. They came back to the same unit, same operating room, same intensive care, same surgical and nursing team. Why? Because they felt they could trust the team, that the team was on their side. That's what open disclosure is all about. In some senses it's a new approach for New South Wales because it's mandated policy. In other senses it's just simply an extension of the good clinical practice that you and I have been part of for many, many years. But it is the start of a system-wide focus on open disclosure. So I hope that you will take the principles of open disclosure and put them into your daily practice. Many of you already have done that, I know. But as part of the health policy, we can be proud that New South Wales is putting this across the whole state as part of the way in which we simply do good clinical care. Thanks.